Good afternoon, everyone. My name is Dominic Akatiba. I'm with Ghana Medical Help. Thank you for joining us this afternoon here in Ghana and at other time zones elsewhere for this webinar on World Kidney Day. Today we are looking at management of chronic kidney disease. The emphasis is going to be on slowing down the progression, especially in a country in which our EGFRs fall precipitously within a year. Uh, just as we are doing this presentation, there's a just ended presentation by one of our legendary professors, Dr. Edu, who I remember always says in his words, the progression of CKD in Ghana throughout his years of practice in Birmingham in the United Kingdom, he's not seen those kind of precipitous falls in the EGFRs. So we have to look at measures of stopping this so that then in the country where access to dialysis, financial muscle to dialysis, and comorbidities surrounding dialysis and all of that are, we can prevent kidney diseases. And those who have kidney diseases, we can slow the progress towards end-stage renal disease because of the financial muscles and all of that that is involved, regards transplant or kidney replacement therapy in general. So we are glad this afternoon that Dr. Kobna Emmanuel Eshon is leading us with a presentation with our head of department, Dr. Ato, supervising him and going to make key inputs as well. I'm excited to join today's webinar. I'm sure you guys too would be. So in the next 45 minutes, we'll have the presentation. At the end of it, we would have some time for some questions, some comments, some additions on this 2026 World Kidney Day celebrations. It's on a positive note that I also make an announcement from Ghana Medical Help that towards our commitment to kidney care in the regions that we are involved in, Upper East, Upper West regions, we are bringing in 17 state-of-the-art dialysis machines of the Fresenius 5008 types. Those who are involved in dialysis will know the technical details regards that optimum standard. We are looking at establishing new dialysis centers in the Upper West region and in the Upper East region, in addition to the two that we have. So at the Upper West Regional Hospital, we're looking at adding about 6 dialysis machines to the single one or two that we have. And then at the Nandom Hospital, we're looking at fixing a new dialysis machine, a new dialysis center over there with about 3 dialysis machines. In the Upper East, we're looking at entering 2 Virgin hospitals at the War Memorial Hospital in Navrongo, setting up a dialysis center over there. And then in Sandoma, where I come from, we're looking at fixing 3 dialysis machines as well in there. We're looking at a total of 17 dialysis machines for the Upper East and Upper West. I know this is going to be a game changer because head to toe, we've always had to struggle with access, especially in an environment where now dialysis is covered by the National Health Insurance Scheme for at least 2 sessions for the people who have chronic kidney disease. So there's no reason why somebody in Upper East or Upper West, due to limited access to dialysis center, the person will not have to have dialysis or would need to relocate elsewhere. So we are happy to contribute to kidney health on this day of International Women's Day, World Kidney Day. Sorry, International Women's Day is still in my mind, right? So on this day of World Kidney Day, so that together with the webinars that we do, together with the staff that we help develop through continuous professional development, and now with establishing centers, we contribute our quota towards developing the health system in Ghana. As we say, it's always everybody's little contribution. This is what we can. What can you do in your small corner? By joining us for this webinar, I'm sure you learn a couple of things. Don't let it stay with you. In our various wards, in our various clinics, please share the knowledge, teach them, highlight the new things that you've learned from here so that when there's that call to action, the person next to you will be able to do the right thing. So thank you so much for joining us. A few household keeping rules that you may have noticed. If you try to unmute yourself, you'll not be able to. This is to prevent people from inadvertently unmuting themselves. As well, if you try to turn on your video, you will not be able to. Again, it helps with the bandwidth for everyone. And then so that people don't mistakenly turn on their videos and we see what we may not want to see. So these are things that you may notice. However, the chat box is open. Kindly put in your comments there, questions, contributions throughout the presentation. And at the end of it, we're happy to have a discussion around it. Once again, thank you for joining us. Dr. Atto, our head of department at the Upper West Regional Hospital, would say a word, and then Dr. Kobna would take us through the presentation. Thank you so much. Dr. Atto, over to you. Dr. Atto, I think your microphone is muted.
Very apt in how you've described. Hello.
Yes, we can hear you now.
Can you hear?
Please, yes, please go ahead.
Yes. So yes, we are looking forward to the dialysis machines, and we know, just like you said, it's going to be a game changer. And thank you for the opportunity once again for us to educate the public on chronic kidney disease. So you've already said it also. I'll just let Dr. Kobina go right into it. Kobina, over to you. Hello, Kobe. Kobe. Can I be
Hello.
heard?
Hello.
Kobe. Yes, yes.
Hello.
Kobe, I can hear
Hello.
you. Kindly go ahead.
Okay. Please, am I audible enough?
Yes, you are. Kindly
Okay.
start.
Thank you very much, Dr. Atto, for this opportunity given me. And thank you very much, Dr. Katiba, for the wonderful opportunity given me. My name is Dr. Emmanuel Kobna, and I'm presenting today on the management of chronic kidney disease. Our emphasis will be on slowing down the progression. Today happens to be World Kidney Health Day, and then as part of this webinar, we'll be looking at how we can slow down the progression of chronic kidney diseases. So we are going to look at the definition and staging of chronic kidney disease, CKD. We'll look at brief anatomy and physiology of the kidney. We'll look at the epidemiology, etiology, the clinical features and investigations. We'll look at modalities in slowing down the rate of progression of CKDs, and then also the criteria for referral to a nephrologist. And the last thing will be our take-home message. So as part of my introduction, according to the 2024 Kidney Disease Improving Global Outcomes KDIGO guidelines, chronic kidney disease is actually defined as structural or functional damage to the kidney for at least 3 months or more, or the glomerular filtration rate or GFR of less than 60 mL per minute per 1.73 meters squared for more than 3 months with or without evidence of kidney damage. Sorry. So chronic kidney disease is actually classified based on the cause, the presence and degree of albuminuria, and then the glomerular filtration rates. Based on the presence of kidney damage and the glomerular filtration rates, irrespective of diagnosis, chronic kidney disease is actually classified into stage 1 to stage 5. So with stage 1, if the glomerular filtration rate is actually more than 90, it's actually considered as being normal or increased GFR with or without evidence of renal damage. Stage 2, if the glomerular filtration rate is within 60 to 80, slightly reduced glomerular filtration rate with other evidence of renal damage. Stage 3 is grouped into stage 3A and then stage 3B. With stage 3A having a glomerular filtration rate within 45 to 59, and then 3B with GFR of 30 to 44. Stage 4, you're going to have a glomerular filtration rate within 15 to 29, and then stage 5, GFR less than 15 as an established renal failure or end-stage renal disease. Okay. So the picture shown here depicts the severity of illnesses of those having chronic kidney disease, looking at the glomerular filtration rates, and then also looking at the albumin urea categories. So when you look at the picture shown, someone is actually categorized as a stage 1 chronic kidney disease when the person is actually having a glomerular filtration rate of more than or equal to 90. This person could actually be having an albumin urea of more than 300 milligrams per gram, or more than or equal to 30 milligrams per millimole. These patients may be considered as normal. However, you could have a patient with stage 3 with GFR of within 30 to 44. However, with albumin urea, when you do your urine albumin, you see that the albumin urea will be more or equal to 300 milligrams per grams. And this, in this sense, even though stage 3 is actually considered as an asymptomatic stage, having an albumin urea of greater or equal to 300 milligrams per grams actually depicts the severity of the kidney damage. So when you look at the color indicators, green actually depicts low risk, yellow depicts moderately increased risk, orange depicts high risk, red actually depicts very high risk, and a deep red depicts highest risk. So briefly, let's look at the anatomy of the kidney. So the kidney basically is actually a bean-shaped organ, and then it's located at the retroperitoneal space on each side of the spine at the level of T12 and then L3. The abdominal aorta actually supplies, at the level of the L1 to L2 will actually bifurcate and then give way to the renal arteries. So you have the renal artery and then the renal veins. The renal artery will actually supply blood to the kidney, and then the renal vein will carry blood out of circulation. And looking at the anatomy of the kidney, you realize that after the blood is actually filtered out of circulation, it actually moves into the collecting duct and then get to the pelvic calyceal system, where the urine now moves through the calyces and into the pelvis and then down through the ureters into the bladder, and now it's passed out as urine. So the kidney, the nephron, is actually the structural and then the functional unit of the kidney. Look at this pictorial view. You have the tubular elements and then the vascular elements. So as I said earlier on, at the level of L1 to L2, the abdominal aorta is going to give way to the renal vessels, the renal artery, and then the renal veins. So within the renal artery, there's also some minute vessels that are also formed. The afferent arteries are going to carry high pressure blood through into the glomerulus, and then filtration is going to occur within the glomerulus. The filtered substances are going to now be deposited within the Bowman's capsule. So the Bowman's capsule is more or less like a cup-like structure where the glomerulus is actually nest. And then any filtration that is done by the glomerulus is actually relayed into the Bowman's capsule, and then moves through the proximal convoluted tubules. At this point, there's reabsorption of certain substances like water, sodium, amino acids. They move through, and then when it gets to the loop of Henle, there's also a reabsorption as well. When it gets to the distal tubules, another reabsorption also occurs at the distal tubules. The collecting duct also will have some reabsorption, and they will concentrate the urine, and then finally deposit it into the pelvic calyceal system, where to actually be passed out as urine. So the pressure within the glomerulus is actually key, because the glomerulus is not supposed to filter, or it's not supposed to allow certain large macromolecules like proteins, like blood cells, to actually seep through it. So if you do any test, you do a routine urine examination, you find out that you are seeing some blood cells inside, you are seeing proteins inside, then it raises an alarm that we need to do further investigation, because under normal circumstances, the urine, we are not supposed to see these large molecules like the albumin, like proteins. We're not supposed to see certain blood cells in our urine. So if you do a routine urine RUNOIC, you are seeing any of these in the urine, that means the glomerulus membrane is actually breached. And so you need further examination to actually come up with what is actually happening. Production of urine actually undergoes three main methods. So we have the filtration, where the blood is actually filtered by the glomerulus, moves it into the Bowman's capsule. There's reabsorption, as I said earlier on, from these tubules, run down from the proximal tubule into the loop of Henle to the distal tubule and then to the collecting ducts. And then also there is the secretion from the blood to the lumen, and then it's now excreted out into the external environment as urine. Globally, CKD stages 1 to 4 is slightly more common in women. It's roughly about 14% than in men, about 12%. CKD in children is more common in boys, typically because usually in boys, we are actually studies say that boys are actually prone to this congenital anomalies like the posterior atrial valves, and so CKD tends to be more common in boys. CKD also is the 9th leading cause of death globally in 2023. Studies have shown that an estimated 788 million adults 28 years and above had CKD in 2023. Then prevalence in CKD in Ghana is about 90% in the general population. However, some recent studies have shown that this percentage is actually more than what is being captured here. And hypertensive patients, actually, the prevalence rate is around 46.9%. Diabetes account for 16.1%. Chronic glomerulonephritis account to 6.6 to 33%. The prevalence of CKD in patients with hypertension, diabetes, and vascular disease is substantially higher. And so screening is actually important and is recommended so that we can capture these populations earlier to prevent the worsening of the kidney issues. More than 25% of the population over 75 years also have an eGFR of less than 60 mils per minute per 1.73 meters squared. And research has shown that as one ages, our filtration powers or the glomerular filtration rate is actually reduced. So typically it's about 1 mil per minute per 1.73 meters squared every year. Right after 40 years, you're expecting that there will be a decline of your estimated glomerular filtration rates of like 1 mil per minute per 1.73 meters squared. So early screening is very much important so that we actually limit the progression of these chronic kidney diseases from being worsened, and then also preventing cardiovascular risk. So what can we actually say with respect to the causes of these chronic kidney diseases? So number one on the list is diabetes. Typically, type 2 diabetes are more common than the type 1 diabetes. Also, hypertension. Those with long-standing hypertension or poorly-controlled hypertension also stand the risk of actually having chronic kidney diseases. People with renal vascular diseases like atherosclerosis are actually implicated here. Also, glomerulonephritis, commonly IgA nephropathy, are also implicated. Other rare causes like mesangiocapillary glomerulonephritis and the others are all implicated. Pyelonephritis and reflux nephropathy are all implicated in the cause of chronic kidney disease. So, moving on, other causes, as I stated, include the chronic interstitial nephritis, obstructive uropathy, and then also people with previous AKI are also stand a chance of actually having chronic kidney disease, certain inheritable causes, such as adult polycystic kidney disease, Alport syndrome, Fabry disease, are all implicated. So how are we going to see, or what are the clinical features, the signs and symptoms of chronic kidney disease? Now, for slower onset of chronic kidney disease, many patients actually remain asymptomatic. So look at those from stage 1 to stage 3. They typically do not come in with any symptoms. However, if there are elevated levels of urea in their system, when the kidney is failing to filter some of these waste products from the body, from the blood, actually, you tend to have higher levels of urea in your blood. And so you tend to have certain symptoms such as anorexia, vomiting, they become restless, they're extremely tired, weakness, itchiness, bone pain, and all that. And then some also will come with some signs of lower urinary tract infection, such as painful urination, dysuria, nocturia. And when you see some of these symptoms, it points towards an acute on chronic picture. So patient probably might have a urinary tract infection, which has gone on to actually worsen the kidney function. And then also in women, we ask, actually, this is something that we usually not ask in our setting. But then research has shown that women, when they come into our consulting rooms, when we are clocking, we are taking history, we ask about their menstrual history. So if you see that a young lady, 35 years, 30 years, is amenorrheic, and then you try and ask further questions, you realize that the LMP is not in consonant with the amenorrheic stage, or you realize that you do a scan, there's nothing showing that there is an intrauterine gestation or something, you need to actually have a higher sense of suspicion that this person might actually be having a chronic kidney disease, because research has shown that those with chronic kidney disease have actually low levels of estrogen, and so it tends to tip them into amenorrheic stage quicker as it's supposed to. And then men also, they tend to have low levels of testosterone, high levels of prolactin, and so because of that, most of them tend to be impotent. So most of the men that come to our consulting room, sometimes they come in with complaints of erectile dysfunction, and then we are quickly to think of other cause other than chronic kidney disease. We also have to check for oliguria. The person is producing scanty amount of urine, or the person is actually not producing urine at all. The patient is anuric. You also have to have a high sense of suspicion. Patients who come in difficulty breathing, patients who are autopnic, patients with some bipedal edema, you also have to have a high sense of suspicion that this might actually be will actually be working towards a chronic kidney disease. So how are we going to investigate patients or clients who come in with some of these clinical features? So, I mean, basically you do your full blood count, you are expecting to have a normocytic, normochromic anemia kind of picture. So your MCV is going to be normal, your MCH is going to be normal, but the patient HB is going to be low. You also have to check your glucose, your RBS, or HbA1c, because you know that diabetes is actually implicated as an etiological cause of chronic kidney disease. You also have to actually broaden your scope and do your standard electrolytes. You do your serum calcium, serum phosphorus, magnesium is going to be high. Alkaline phosphatase, your PTH levels will be high. You do your renal function test and you realize that the markers, the creatinine levels will be elevated, urea levels will be elevated. Sometimes you might even be having potassium also being elevated. So we have to actually make sure patients who come to our consulting room, these basic labs are being done. Full blood counts, random blood sugar, HbA1c, serum electrolytes, do your BUG and do your lipid profile. Because usually most patients with chronic kidney disease, there is reduced clearance of the LSAT, the lecithin, the LSAT actually. So if you fail to actually do your lipid profile, and then you think that, oh, these patients may not be having a high levels of LDLs, it might come out that these patients have higher levels of LDLs. And most of the times, if we are even awaiting lipid profiles, we sometimes even start treating for hyperlipidemia, because patients with chronic kidney disease tend to have hyperlipidemia. So sometimes we tend to even start the statins even when we've not had the lipid profiles results yet. You can also do your urine RE and urine CSS. There's any evidence of urinary tract infection or any evidence of urosepsis. We do a urine albumin creatinine ratio as well. If you are thinking of a DM nephropathy, you do your abdominal USGs to look at the kidneys. Typically, you expect the kidney size to be around 10 to 12 centimeters. So if there are any asymmetries in the kidneys, you consider Mark 3 renogram. The Mark 3 renogram is actually a nuclear medicine imaging test, which actually evaluates the kidney function, tends to look at the blood flow and then the urinary damage. But then in my practice, I've not actually seen this being done in our system. Histologically, you can also do a renal biopsy if there is a rapid progressive disease, or if there is an unclear cause of the chronic kidney disease, or you realize that you do abdominal USG and the kidneys are normal, but then the structure of the kidneys are normal. However, the function of the kidney is impaired. So with the management of CKD, there are 4 main approaches. We look at the investigations, we look at how we can limit the progression of the complications, symptoms control, and then finally renal replacement therapies. But for purpose of our discussion, our focus will be on how we can limit the progression of chronic kidney disease. So one, management of CKD focus on slowing down progression is grouped into non-pharmacological, which is like ones without drug therapy, and then pharmacological. With non-pharmacological, basically you're looking at lifestyle modification, restricting salt intake, less than half a teaspoon of salt per day. That's like 5 grams per day of salt, or less than 2 grams of sodium. So we have to keep note of that. And then also, we shouldn't be used to adding salt to our diets. Usually, we like to add a lot of salt in our diet. People like to include momoni, kobe, and others in their diets. It's actually not healthy. We also have to inculcate the habit of eating balanced diet, consume more plant-based foods, animal-based foods, increase the intake of fruits, vegetables, and reduce the intake of carbohydrates. We are also encouraged to have moderate intensity physical activity, a total of like 150 minutes per week of exercises, encourage weight loss if you are obese, patients with obesity and then CKD. BMI target is actually less than 25 kilograms per meter squared. We're also advised to encourage hydrating, especially in areas where the weather is very warm. We are also encouraged to control our blood pressure, because we know hypertension is implicated in chronic kidney diseases. So in adults with high BP and chronic kidney disease, our target systolic is BP less than 120 millimeters of mercury. Less intensive BP target in people who are frail, weak, have symptomatic posterior hypotension, would want to not actually have a very low systolic BP because of the symptomatic posterior hypotension. So we are also advised to have our sugars under control. So you want to keep the fasting blood sugar between 4 to 7 millimoles per liter. For very ill and elderly patients, fasting blood sugar should be kept between 6 to 8 millimole per liter. And then you expect your glycated hemoglobin to be less than 7.0%. For early CKDs, like stage 1 to stage 3, you expect your target HbA1c to be less than 6.5%. And then advice is also, we advise that caution should be taken with aggressive targets in elderly patients who are actually at risk of hypoglycemia. Moving on to the pharmacological therapies, there are 4 medications that are actually implicated broadly, that are actually indicated. So we look at 1, the angiotensin converting enzyme, the ACE inhibitors, example like Sinopro, Ramipro, and then also angiotensin 2 receptor blockers, ARBs, such as Losartan, Valsartan, sodium glucose cotransporter 2 inhibitors, such as dapagliflozin and then empagliflozin, glucagon-like peptide 1 receptor agonist, example semaglutide and then liraglutide, then melanocorticoid receptor antagonist, such as finerenone and then spironolactone. So I'll skip this. This is actually mechanism to show how blood pressures are put under control when you have very low blood volume. You realize that there's some compensatory mechanism that has to come in play. The RAS system will have to come in play to try and then retain sodium, retain water, and then increase our blood pressures. So if we want to slow down progression of chronic kidney disease, instigating renin-angiotensin system inhibitors tend to actually reduce or slow down the worsening stage of chronic kidney disease. So this diagram actually shows the effects of ACE inhibitors on the glomerulus. You realize there's high pressure in the glomerulus because of the afferent arterioles actually bringing in more blood into the glomerulus to be filtered out of circulation. So our goal is to actually reduce the pressure within the glomerulus. So when we are reducing the pressure within the glomerulus, we are in turn actually reducing the severity or the risk, or reducing the rate at which chronic kidney disease gets to an end stage. So the KDIGO, that is KDIGO 2024 CKD guidelines concerning renin-angiotensin system inhibitors actually states that renin-angiotensin system inhibitors should be started in patients with CKD with moderately to severely increased albumin urea, with or without evidence of diabetes. RASI can also be started in chronic kidney disease with normal or mild albumin urea. And then also ACE inhibitors or ARBs, as I mentioned, can also be continued if you have an eGFR that falls less than 30 mils per minute. So this picture actually depicts how we can monitor serum creatinine and potassium during the administration of ACE inhibitors or ARBs, because of the fact that one of the side effects of ACE inhibitors is the increased levels of potassium in our blood system. And if you don't have the luxury to be doing serial serum creatinine level check or serum BE checks, you realize that patients come in with chronic kidney disease. We want to actually slow down the progression. We are giving ACE and ARBs, but then they could actually dip into arrhythmias because of hyperkalemia. So if you have a patient with normal kalemia, with eGFR less than 30%, with normal kalemia, you are administering ACE or ARBs, you tend to have a less than 30% decrease in the eGFR. So with patients like this, you can increase the dose of the ACE inhibitors or ARBs, or you can continue on maximally tolerable doses. Patients on ACE inhibitors or ARBs with hyperkalemia, you want to review the drugs. You want to actually moderate their dietary intake of potassium. You want to consider diuretics, sodium bicarbonate, and also potassium binders in such cases. And then also those with ACE or patients on ACE inhibitors or ARBs with more than or equal to 30% decrease in their eGFR, you want to review these medications for causes of AKI, whether it's pre-renal, renal, or post-renal. You want to correct any volume depletion You want to reassess concomitant medications such as diuretics or NSAIDs, and then consider also renal artery stenosis in such situations. With KDIGO 24 CKD guidelines concerning SGLT2 inhibitors, so they stated that you can use ACE or ARBs. Other medication that are also implicated is the SGLT2 inhibitors. SGLT2 inhibitors should be given to patients with type 2 DM. And then with eGFR greater or equal to 20 mils per minute, SGLT2 can be given. Once initiated, SGLT2 inhibitors should be continued, even if the eGFR falls less than 20 mils per minute, unless it's not tolerated, or SGLT2 inhibitors also can be withheld. In times of prolonged fasting, patients who are undergoing surgeries, or those who are critically ill due to the risk of ketoacidosis. SGLT2 inhibitors can also be given in CKD with 1 eGFR of greater or equal to 20 mils per minute with urine albumin creatinine ratio of greater or equal to 200 milligrams per grams. Then also patients with heart failure, irrespective of the albumin-urea levels, you can give them the SGLT2 inhibitors. Those with eGFR from 20 to 45 mils per minute with urine albumin creatinine ratio of less than 200 milligrams per gram can also benefit from SGLT2 inhibitors. So studies have shown, and certain research has come up with DAPA CKD trials, which is actually a randomized control trial that's demonstrated that DAPA 10 milligrams given daily significantly reduces the risk of kidney failure, cardiovascular death, or renal death to about 39% in patients with chronic kidney disease, both with or without diabetes. So there is the DAPA CKD trial and there is the EMPA CKD trial. The EMPA CKD trial as well is also a randomized control trial that actually demonstrated that patients who are on empagliflozin significantly reduces the risk of kidney failure, cardiovascular death, and the renal death by 28%. And in such patients with or without diabetes, when they administered EMPA, they tend to reduce the risk of these complications. Then also, mineralocorticoid receptor antagonists are also implicated here. Steroidal MRAs, example, spironolactone, may be used in heart failures, hyperaldosteronism, or refractory hypertension. Those who are on BPs like more than 5 or 4 or more BP medications, but still their BPs remain higher, you can add on MRAs. Non-steroidal MRAs, such as finerenone, can be added in type 2 DM with eGFR more than 25 mils per minute or normal potassium. Patient also with albumin-urea of more than 30 milligrams per gram, despite maximum tolerable dose of the RASI. MRAs has been shown to reduce blood pressures and then albumin-urea in chronic kidney diseases. There is also a trial, the Fidelio DKD or Figaro DKD trial. This trial actually demonstrated that the benefit of finerenone, which is actually a non-steroidal MRA, tend to reduce risks for kidney and cardiovascular outcomes. Then also, GLP-1 receptor agonists, such as semaglutide and then liraglutide, are recommended in type 2 DM and then chronic kidney disease who have not actually achieved a good glycemic control, despite the use of metformin and then SGLT2 inhibitors, or those who are unable to use these medications. You can also administer GLP-1 receptor agonists to such patients. So how can we actually manage or slow down or prevent cardiovascular diseases from happening? So persons aged more than 50 with CKD, studies have shown that you can use statins or statin with ezetimibe therapy in EGFR of less than 60 mL per minute, patients not on dialysis or kidney transplantations. We can also use statins in EGFR greater or equal to 60 mL per minute. For persons aged 18 to 49 years with chronic kidney disease, studies have shown that the usage of statins, if they are on dialysis or kidney transplantation and have one of the following: one, a history of a coronary artery disease, being it MI or coronary revascularization, diabetes mellitus, previous ischemic strokes, a 10-year estimated incidence of coronary mortality or none. So a 10-year estimated incidence was actually brought up to actually depict that patients who are on this medication tend to have a reduction in the cardiovascular diseases or reduction in the incidence of cardiovascular conditions. The use of oral low-dose aspirin for prevention of recurrent ischemic cardiovascular diseases are also implicated. Let's look at how or when to refer a patient to a nephrologist. With EGFR less than 30 mL per minute per 1.73 meters squared, patients with uremic complications like uremic gastritis, uremic encephalopathies, persistent albuminuria with urine albumin creatinine ratio of more than 300 milligrams per grams, patients who have an acute kidney injury or an abrupt sustained fall in glomerular filtration rates, and then also those with atypical progression of chronic kidney disease, i.e. with rapid decline of more than 3 mL per minute per 1.73 meters squared per year. Also, patients with refractory hypertension, as I stated earlier, you do your urinary, you see urinary red cell cast, or someone is plain persistent hematuria. There's also, when there's also persistent abnormalities of serum electrolytes like increased levels of potassium or sodium, in situations like hereditary kidney diseases, patients with recurrent or extensive nephrolithiasis. So what are the take-home message? Today happens to be World Kidney Day. We are going to look at the 8 golden rules. The first one is that we should stay fit, eat a healthy diet. So as we spoke earlier, there is a non-pharmacological and then a pharmacological. So typically, most of these things are more of the non-pharmacological approach. You stay fit, you eat a healthy diet, control your blood sugars, monitor your blood pressures, you hydrate well, especially those in warm areas. You avoid smoking as it's shown to cause certain endovascular damage and can actually worsen the kidney function. You limit over-the-counter painkillers, patients or people who actually sustain headache, people with any form of pain tend to just resort to the over-the-counter drugs. They tend to take in NSAIDs, and these are shown, research has shown that these medications tend to reduce the kidney function. We also are admonished to check our kidney function regularly, especially in high-risk situations. These are my references: Davidson's 24th edition, Oxford Handbook of Clinical Medicine, Medscape, and Ambos. Thank you.
Thank you very much, Dr. Kobina. I think it was well delivered, and you really took your time to emphasize on the whole point of this afternoon's presentation, which is how we can slow down the progression. So thank you very much. I don't know if Dr. Katiba has anything to say before maybe I give a few comments. Then we will look at the questions.
I think it was an excellent presentation, very straightforward, and we've been able to do it within about 40 minutes. So this is great. And I'm sure lots of us have picked the important points he stressed on. So we happy you can pick up, put in your comments, and then we can take the questions and we get out of here. Thanks.
Okay, so maybe whilst you are waiting for questions, we'd just like to reiterate the point that in the initial phases of chronic kidney disease, most of the time we are asymptomatic. So once in a while, do well to just, even if you don't have any symptoms, do well to enter the lab and just check your kidney function, because the commonest presentation is actually no symptoms. So you would be there thinking everything is fine. And by the time you are told you have kidney disease, it probably might be advanced and to the point where you have to do a renal replacement therapy. Fortunately, we've started doing renal transplants, except that we are still very early in years of our renal transplant in Ghana, and we don't even have the right legislation that is actually in it. There's still a lot of work going on, and it's still a sore from getting to that advanced stage that will require a renal transplant. There is a general rule of thumb which I just want to share with the rest of the house, which we call the 30-20-10 rule, and it's a general rule of thumb that can easily help you and guide you as to what to do when you see a patient with kidney failure. So the 30-20-10 rule, the 30 is EGFR of 30. That means that at EGFR of 30, you should be referring the patient to see either a physician specialist or a nephrologist. When the EGFR is at 20, you should be discussing with the patient for vascular access. Vascular access here includes your arteriovenous fistula or your grafts for your dialysis and so on. And the 10 is at EGFR of 10. You should actually be discussing, be in discussion with the patient as to how to initiate the patient on maintenance dialysis. Most of the time, especially in our environment, we don't see it happening a lot of time, but we always wait for them to get into an acute kidney. We always wait for an acute indication before we start the dialysis, and that may not always turn out well for the patient, because when uremia sets in, the complications can be quite untoward. So we want to discuss with them how to initiate them on maintenance dialysis even before they develop the signs and symptoms of uremia. So that's just what I want to share with the house, the 30-20-10 rule. And just want to throw a bit more light on the dyslipidemia. And for the most common dyslipidemia in CKD patients tend to be hypertriglyceridemia. Typically, their total cholesterol tend to be okay. And some studies have said that it's because of the malnutrition. You know, anorexia is part of the symptoms or the symptoms of uremia. So most advanced CKD patients will have anorexia and they don't tend to eat well. So a lot of them tend to be malnourished. And if you don't make a conscious effort to refer them to the dietitian or to try and supplement their diet, it actually has a great impact on their overall morbidity and mortality. And we've seen quite a lot of it in our setting where most of our CKD patients tend to be malnourished. So we are taking steps to ensure that we try and supplement their diet, and it's not really their fault. They just don't feel like eating anything. They become anorexic, and that is actually one of their symptoms. So we should also take note of that. And I also want to throw a word of caution with the use of the mineralocorticoid receptor antagonist. With if you look at the KDIGO guidelines, it refers more to the non-steroidal, and the non-steroidal one that was used in the trial, in the Fidelio trial, was actually finerenone. So let's be cautious not to put patients on spironolactone or eplerenone, especially if we don't have the capacity to monitor their potassium. Thank you very much. Maybe we can take a few of the questions. I think I've seen one or two in the chat box. So Dr. Joseph wants to know, a diabetic patient on SGLT2 inhibitor, DAPA, had a complication of euglycemic decay, and SGLT2 was found to be the culprit and was stopped. Please, should it be restarted now that the patient is doing well? or not started again since it came with that complication. Thank you, Joseph. That's a very good observation. SGLT2s have been found to cause euglycemic decays. And if you look at the 2024 KDIGO guidelines, what they advocate is that you should individualize the care of your patients. And now we've moved from doing the general base to more individualized care. So you want to individualize the care for this particular patient. If the DKA has been solved and the patient is doing well, I don't see why the patient cannot be started again on the SGLT2, looking at the immense benefits that they would derive from the SGLT2 long term. Remember that the SGLT2's benefit is more long term. If you look at the studies, the DAPA-CKD and the EMPA kidney trials, most of the benefits were seen after 2 years. So the longer they are on it, the better. So once your DKA has been resolved and the patients are doing well, I don't see why it cannot be restarted with the patient being monitored carefully. I don't know if maybe my boss will add something to it, but that is what I think.
Yeah. So I think the thing is that yes, if you restarting it, especially because the DAPA is the precipitating agent, it has to be under specially supervised kind of restart, because the bigger chunk of it, the risk is more or less like what we call a re-challenge, because if it's a specific precipitant as the SGLT2, restarting it very early sort of would be re-challenging the kidney, and that as well can tip you back into the euglycemic decay. But I totally agree with you that once things are fine, the patient is out of the DKA, is stable, and all of these indications are out of it, where the clear precipitant has been taken off. If there's a co-precipitant, like maybe some infection that may have added to it or any of that, then if you're clear of that, you could, under specialist supervision, restart it. Just to be careful that then you would not push the patient back into a euglycemic decay. Meanwhile, once he's off it, if you need to control that sugar, there are always alternatives that you can put in, including insulin itself. And then once he's out of the decay, then you can look at the long-term measures like Dr. Atto rightly mentioned. All right, over.
Thank you very much, Doctor. So Raphael wants to know if we can get the presentations and the slides. Yes, I think Dr. Katiba has responded to that. Is there any legal regulation? Yes. So like I said, there are some policy framework discussions going on. To the best of my knowledge, it's still incomplete, and but the process is already underway. So I'm sure that our bosses up there would try and finalize things sooner rather than later, especially now that we have it on the rise and a lot more young people. I heard a very alarming statistic by the Honorable Minister of Health yesterday that about 40 to 45% of mortalities in Ghana are from kidney diseases. So it's not something we should play with. I'm sure very soon they'll finalize the law and the policy discussions, and maybe once they do, we would have a proper legislation that can actually regulate kidney transplants in Ghana. Thank you very much. So can a diabetic patient be put on both metformin and SGLT2 inhibitor? Yes, if there's no contraindication, why not? Why not? There are two different classes of medications and they act differently. So if there are no contraindications, it definitely can be put on both together. Please, is a creatinine level of 81.6 micromole per liter normal? For most laboratories in Ghana, that is actually going to be normal, but you always have to confirm with the laboratory values that you've been given. Some of the labs have different reference ranges, so you have to compare to the reference range that you have. Upon chairman, great presentation. What is the target blood pressure and HB in CKD patients? Also, what amount of protein is allowed per day? That's a good question. So if you look at the 2024 KDIGO guidelines, the systolic target is actually 120. All right, so that's directly from the KDIGO 2024. You can have a look at it, but it's about 120. And the HB, normally what they say is for patients who come with advanced CKD, most of them, their HBs will settle around 8. So the recommendation is that you shouldn't wait for it to get there. Usually, when the HB drops to below 12 for women and 13 for men, immediately at that point, you have to start doing your iron studies and start replenishing iron if there's any iron deficiency, because we know most of them will get iron deficiency, anemia, or anemia of chronic disease, and the IGs will tend to drop, especially because of the role of the erythropoietin. So usually once the IGB starts dropping below 12 for the women and 13 for the men, you immediately have to start doing your iron studies and replenishing their iron. But if you wait and they become advanced, most of them will actually settle around 8. And so that's what I can say to that. With regards to the protein, still on the 2024 KDIGO guidelines. So I mean, I'm referencing that a lot because KDIGO is like the global authority when it comes to kidney diseases. So they say we should avoid high protein diets, especially for those with CKD. And the target is about, they said you should per day, you shouldn't do more than 1.3 grams of protein per day. And usually the limit is actually up to about 0.3 grams and grams per kg per day for those in G 1.3 grams per kg per day for protein. And that is straight from the KDIGO 2024 guidelines. So that's what amount of protein is allowed. So once you have the just multiplied by 1.3 grams, you get your total for the day. You get grams. Right. Hypertensive crisis in obstetrics like preeclampsia, that can become chronic when you have hypertensive disorders in pregnancy. If that's what you mean, then yes, there's always that risk of becoming chronic once you have hypertensive disorders in pregnancy. And so that risk is there's also one of the risk factors. For most people, once their BPs are well controlled and they are delivered, they tend to return back to normal status. If they are not, you just have to follow them up with a specialist and make sure that they do not become chronic. If they become chronic, you put in the measures that we've put here to ensure that they do not progress to get to the end stage. I don't know if that answers your question. If that doesn't, you can please come again on the question. Great presentation. Please, there is a growing production and intake of some assorted drinks in the Ghanaian market with various names and colors. Do you think these are safe for consumption as far as the kidney health is concerned? We've actually realized that a lot of young people are coming in with chronic kidney disease. So my initial thinking is that the risk factors cannot just be related to the traditional risk factors that we all know of. So hypertension, diabetes, and dyslipidemia, and smoking, and all that. There must be more. And some studies have shown the increasing usefulness or increasing, they've implicated they've had some genetic, especially in the Black population. If you look at some of the research that has been done, isolating the apolipoprotein 1 and its role and all of that. I think we need to do more research on it, but definitely there's a lot of anecdotal evidence to suggest that some of these energy drinks contain certain chemicals that actually increase our risk of kidney diseases. But we definitely need more evidence to be able to come to that firm conclusion, because you know that as it stands now, most of it is mainly anecdotal, and we will need to have randomized controlled trials or maybe some meta-analysis to have a firm conclusion when it comes to that. But that's what I think. Definitely there may be a role. They definitely will play a role, but more research is needed in that space. I don't know if that answers your question. If my boss would like to come in before I continue.
Yeah, I think one of the key things that I just wanted to highlight was this, apart from the energy drinks he's talking about, a lot of people mix a lot of stuff, right? Especially the aphrodisiacs, herbal-based aphrodisiacs. Lots of these guys have, or these drugs have lots of nephrotoxins. So people take them, and then there was a case we saw in Wa where a young man had mixed a lot of things, right, and then his kidneys shut. So sometimes those have been sort of case reports that we do see, and obviously the load that they put on the liver with a lot of the sorbitol and all of that they add in there, and the herbal medicines that have not been approved. I'm sure they account for why, like I said, one of our legendary professors keeps mentioning that there must be something in addition to the traditional risk factors, like you mentioned, that is just causing a lot of this downward trend that we are seeing. So there has to be evidence-based. The name of the game is evidence-based medicine. So we may postulate, we may think these are the things, but unless we do research to be able to pick up those items, we run some trials to be able to pick it up, then we can confirm that yes, this is it. The challenge that we have is in a country, a third world country, becomes difficult with regards to funding for such kinds of research, and that's how come we are lacking behind the rest of the developed world, and we seem to usually adapt or wholly adopt to whatever they put in. Yes, so I tend to agree with you. Thanks, and over.
Thank you very much, Dr. Katiba. So we'll continue with the rest of the questions. So Bashit Mahama wants to find out, at what stage do you start to discuss renal replacement therapy with the patient? And if you remember, I gave a general rule of thumb, which is the 30-20-10 rule, right? And the 30-20-10 rule, at EGFR of 30, refer them to see a specialist or a nephrologist. And 20, that's when you discuss vascular access. 10, you should be thinking about initiation. So basically, if you ask it broadly, then I would say that by the time they are around 30, below 30, you should be having that discussion. The reason why I say that is that it helps if that discussion is had very, very, very early. And normally for some people, because they do not have very good when you suggest it. But if, of course, are discussing with them, it prepares disciplinary, or for them to see dietitians, let them see psych, let them see your dialysis nurse specialists, like refer them to other people. It should be a decision so that everybody sits down, this is discussed with their family, and they tend to make a decision. That decision, it's much better you waiting for them to go into acute uremia, and you have to now dialyze them as a case of an emergency. Then subsequently, studies have shown once they get into uremia and you dialyze them, they tend to come with a lot of other complications. Sometimes the prognosis is not even very good. So the earlier the better. Of course, don't go scaring everybody at EJ or 30 that no, you have to do dialysis. This week I had a patient like that, and they were worried. I'm like, oh no, you don't need dialysis now. But this, I'm sure it was just to prepare you. So I think that a very good time to discuss would be when they get to around 4 months. We will be you know, around that is a good time to start talking to them about it. And you have to also individualize the care, like I said, in our setting, like but they are progressing so fast. So sometimes somebody very some of them their possibility presentation, looking at the large number of nurses following. So some it's the possibility of incorporating nursing care management interpretation, looking at the large numbers.
Absolutely, definitely.
Okay.
So, great
If
call.
I'll continue.
We are happy to take on the nurses. So, if you are interested in leading us with such, kindly just send me a message, or you can join any of the platforms that I've put up, and then we'll be glad to take you on. Like I mentioned, we can't pay you for what you do, but we usually offer you some amount for your time. Thanks, and over. Yeah, can you guys hear me? Dr. Kobner, can you hear me?
Yes, please.
Yes, please. Okay, I think I may have dropped off Dr. Atto as well. So yes, I was saying that for the next that express interest in leading the presentation, we are happy to take you on, definitely. So if you look in the chat box, I've put in the various social media handles there. If you don't have my number, you can reach out through any of those social media handles, and we'll be happy to put you on. So anyone interested in helping to learn, helping us to teach ourselves, it is within ourselves that we're doing this. Just reach out and we're happy. Thanks so much for bringing it up. Dr. Atto, over to you.
Thank you very much. Sorry about that. I think I also dropped off. Yes, I was saying that iron deficiency is one of the main causes of erythropoietin resistance. So if you are going to give a patient iron deficiency erythropoietin, then it means the iron stores will have to be replenished. So if you are going to do that, replenish your iron stores, or whilst you are doing it, you'll be replenishing your iron stores alongside. Then you can do that. All right. Okay. Please, are all brands of that good? We recommend. Unfortunately, I can't name any specific brands, but dapagliflozin is dapagliflozin. If you want, you can go to the originator brand. I don't know if I have permission to mention it, but I don't want to mention any brand. And the others also came out. If you are sure the DAPA you are getting, you can always unfortunately time is fast spent. I'll hand over to my boss, Dr. Akatiba, to continue. Thank you all for joining.
Thank you as well, Dr. Atto, for the legendary expertise that you brought to this discussion. Great. So we are glad that you could join us for today. We want to say a big thank you to Dr. Kobner for leading us with this presentation. Very straightforward, very concise, kept to the time, and then brought out the important aspects of it for us to be able to take home. This has been good. Please make a date with us next week, same time, for another presentation. So we are grateful to all of you for joining us. God bless all of us and take care. Bye-bye.